Hi, I'm Bill Rapisi, Executive Director of Lymphatic Education and Research Network, and I just want to take this opportunity to thank all of you for joining us today for our symposium series. I also want to take this opportunity to thank all of you who have become members of LE&RN and help support this series so that we can continue bringing this kind of groundbreaking information to you in your homes and offices. I would also suggest for all of you who have not become members of LE&RN, $5 a month, you can become a member of LE&RN and help support this programming and the research that we do. Thanks very much for joining us, and I look forward to having you become a member.
I'm a family physician. I'm also a certified lymphedema therapist, and I'm a person with lymphedema. On researching lymphedema and the treatment, and the American Cancer Society held the one and only workshop in 1998 to evaluate the state of lymphedema therapy in the United States. At that point, they found that for many women, lymphedema was not only a debilitating condition, but also a daily reminder of the healthcare system's failure to educate them appropriately and to respond effectively to their condition. Breast cancer-related lymphedema gets the majority of the education and information around lymphedema because we'll discover it's federally mandated. However, this is not the only form of lymphedema that exists. Again, in 1998, they found that patients and their physicians generally do not know where to obtain treatment or how to assess the quality of available treatment resources. And I wish that was historical. But in the journal American Family Physician that was just released, the peer-reviewed journal for my specialty, when they reviewed care of the adult cancer survivor, their comment on lymphedema was that evidence for effective treatment is limited. The one article they referenced was over 10 years old and actually did not come to that conclusion. But a busy family practice physician reading this, if they found a patient had lymphedema, would believe that there is no evidence that there's effective treatment for lymphedema. In 1999, a New York City newsletter devoted a page to the same topic, and basically it parallels today's talk. You want to have a physician or other provider who knows about lymphedema. This is so important. You need to educate yourself about the condition. You need to find a certified lymphedema therapist, learn how to take care of your own lymphedema, and receive the appropriate treatment. The history of lymphedema in the United States is actually quite short. In 1960, Dr. Casely Smith first published about lymphedema in Australia. In 1979, the Foldy Clinic was founded in Germany, which provides an inpatient model of lymphedema care. In 1988, the National Lymphedema Network was founded in response to the awareness that patients were not receiving good care for their lymphedema. In 1990, Dr. Robert Lerner started the Lerner Lymphedema Services in New York City, which essentially was a day treatment intensive program providing services similar to the Foldy Clinic. And many of the practitioners who currently operate lymphedema training schools worked with Dr. Lerner. In 1998, very few insurances covered lymphedema therapy, but that was somewhat rectified when the Women's Health and Cancer Act right was passed, which mandated that lymphedema secondary to breast cancer be covered. However, even today, Medicare does not cover garments for breast cancer-related lymphedema. In 2005, Medicare decided to restrict reimbursement of lymphedema therapy to only physical therapists and occupational therapists, and this changes how lymphedema care is delivered in the United States. The training requirements, they've evolved over time, but at this point, we believe that the ideal training requirement is a 135-hour course, which allows you to become a CLT, a Certified Lymphedema Therapist. These guidelines are set by the National Lymphedema Network and the Lymphology Association of North America. The American Physical Therapy Association, however, believes that any physical therapist can provide lymphedema treatment without specific training. The American Occupational Therapy Association has no specific requirement or policy around this. The current training schools, and these are always in some evolution, the North American Lymphedema Education Association is Guenter International, Klose, American or Academy of Lymphatic Studies, and Norton. Leduc is based on the West Coast, and incorporates pumps. Casely Smith is the Lazinski and CLT courses. Monarch is a more recent school. There still are short course seminars, and there are some former schools, Lerner, Uplinger, Kesslinger, lymphedema consultants. Realize that all schools offer training which is less than a full CLT certification. My personal history, 10 years after the American Cancer Society lymphedema workshop, I developed breast cancer lymphedema. I discovered that the same concerns that were raised 10 years previously existed. And when I looked up lymphedema in my oncology textbook, I discovered that the comment was therapeutic nihilism, which was the inability to recognize and to refer patients for treatment, was deplorable although common. And again, I find that still to be prevalent. Initially, I was lost. I had been in practice for over 21 years. I'm an educator. I knew nothing about lymphedema. I didn't find any of my treatment team willing to guide me, so I found my guidance on an online forum at breastcancer.org where some wonderful, devoted women took care of me and helped me learn about lymphedema therapy and helped me find my way to finding a good therapist and getting the treatment I needed. We banded together and created stepupspeakout.org, which is a website devoted for patient education around lymphedema. I have a wonderful lymphedema therapist. I've also seen other fully certified lymphedema therapists. And unfortunately, because there are no minimum standards and there is no oversight overall, I've found the care to be lacking at times. But once I became educated, I was able to get the care I needed. Ultimately, in 2012, I became a CLT. Again, I'm a physician. I would have thought I would have known more. On my last set of boards, there was one question devoted to lymphedema. My medical students in general know nothing about it, and it's not in their curriculum. Even in oncology curriculum, lymphedema does not tend to be covered. And again, I was under the care of 2 fully qualified lymphedema therapists as I developed lymphedema and found that the care really didn't meet my needs, unfortunately. I had the honor to work with radiation oncology practice and work with oncology patients for 3 years after developing lymphedema, and I found a lot of lymphedema in highly compliant patients that saw all the members of the clinical team, but no one seemed to own their lymphedema. People didn't look, people didn't refer them, so I found a lot of cases. Again, if you look, you find. I currently work at a community health center and I see a lot of primary and secondary lymphedema. And again, just teaching my medical students how to take vital signs, I have to educate them about lymphedema, as you really don't want to be putting a blood pressure cuff on an arm with lymphedema. Knowledge is power. If you understand treatment and lymphedema, you can find a good therapist and have a great working relationship. The first step is to determine their training. Again, to become a CLT, you need to receive 135 hours training. 40 hours are didactic, the remainder is in the classroom, both lectures and working on each other. But beware, all the schools offer partial training, so someone can tell you they're trained by Klose, but they may have only taken a short course. Also realize that when I finished medical school, I got an MD, but I still needed to do an internship. When someone becomes a CLT, they go out into the workplace and they may not have a guidance or oversight as they practice, and there is a steep learning curve. So the first questions to ask a lymphedema therapist is, are you fully trained? Where did you get your training? Do you have continuing education? VADR has always had recertification, where students actually go and are watched to make sure that their technique is appropriate. Recently, ACOLS and Norton have instituted recertification. You want to know, do people meet LANA standards? LANA was created in 2000 to attempt to set a minimum standard for lymphedema therapy. It was 135 hours of training and a year of clinical practice. Recently, the year of clinical practice was dropped. Then one needs to take and pass the exam to become LANA certified. LANA doesn't supervise the therapist that it certifies, but it does create a minimum standard. You want to know how much of the therapist's practice is devoted to lymphedema. Do they just see an occasional case, or do they see it a lot? Again, once you're trained and you go into practice, there's a steep learning curve. Physicians can be trained in new procedures, but when we go back to our institutions, we're usually proctored by someone more experienced. So I'm not saying avoid a newly trained therapist, but no, in the clinic, you learn a lot as you come up with challenging cases. Resources on the net. There's Find a Therapist website on our website as well, and you can also search LANA for a LANA certified therapist. Additional net resources on YouTube. Guenter Klose has a wonderful video going over lymphedema and lymphedema therapy. Myself, the Northwest Lymphedema Center self-care videos were so important to me. I watched them again and again once I was newly diagnosed to learn about the disease and to learn about self-care. And the Lymphedema Education and Research Network has online resources as well. I highly recommend Joe Zuther's blog as well. The next thing is to understand treatment. Treatment is going to be individualized for everyone. So the standard treatment is called complete decongestive therapy. The first step is diagnosis, and you need to know there is no diagnostic criteria for lymphedema. As Andrea Chaville has said, who is an MD at Mayo Clinic, there is no one test that can tell you whether you do or do not have lymphedema. We like to be objective. We like to be scientific. So you may find that someone says to you, you need to have a 10% volume increase. You need to have 2 centimeters difference. But know that lymphedema is a clinical disease, and it's static. It's not static. It changes over time. So although we want to quantify it, understand that it's a clinical diagnosis. The next step is manual lymphatic drainage, which looks like massage, but it's basically understanding the lymphatic system and moving stagnant fluid to an area that can receive it and drain it. Then multi-layered compression bandaging is a powerful tool to decongest an area. Compression garments are very important. Therapeutic exercises to move fluid, and self-care, because you need to live with this condition and know how to take care of it. Self-care is self-manual lymphatic drainage, exercises both therapeutic and strengthening, monitoring, getting the garments, and skin care. Lymphatic anatomy is crucial to understanding the disease. This is a wonderful slide from Solaris Corporation, and the important thing to note is that our lymphatic system is essentially divided into quadrants, much like a quartered chicken, with the head as the 5th quadrant essentially. So if someone has their nodes removed in breast cancer, in the axillary nodes, their entire quadrant is at risk. That's their breast, their trunk, their abdomen, their arm, and their back as well. And in lymphedema therapy, what we do is remove the stagnant fluid and find an area that is functioning that we can move the fluid to. If all 4 quadrants are not functional, we can move the fluid to the deep collectors. This is a sequence of manual lymphatic drainage for a swollen arm. The key is that we clear the core first. So it's like moving a traffic jam. You need to get those first cars out of the intersection before the remainder can come through. We clear the neck. We open up the axilla that's not affected. We open up the inguinal nodes. We move the fluid down and across. We move it across the watersheds on the back. And only then do we then decongest the arm. We always move from close to far, from proximal to distal. This is another example of drainage of the arm. The neck is many, many lymphatics, and it's called the core and the terminus, and decongesting the neck is essential. Clearing the abdomen is a very powerful tool, and you can place your hands in these 5 positions and resist your hand with breathing or do some manual lymphatic drainage. Many patients tell me if they just clear their neck and clear their abdomens, their swelling in other portions of their body is greatly relieved. What to expect? During your evaluation, it's not just volume. You should be talking about your symptoms, what makes it worse, what makes it better. You may receive complete decongestive therapy if that's appropriate, and patients are often bandaged for many days on end while receiving manual lymphatic drainage. You need to leave with your self-care toolbox. Coping strategies. This is a chronic condition, or at least a risk of a chronic condition, so you need to know skin care, triggers, infection, how to handle travel, protection, don't let someone give you a flu shot in that arm, and how to keep an eye on the area at risk or the area affected. Questions to ask. The garments. How are you going to get the garments? I was trained for 4 hours and considered a fitter, but I actually rely on someone with 20 years experience for my own garments. What will my individualized treatment plan be? How is it compared to the National Lymphedema Network's position paper on treatment? How will my visits be scheduled? How will I have maintenance visits, as this is not just an acute problem? How can I contact you when I have questions? More special circumstances, distance from the therapist, no help at home, limitations due to arthritis, neuropathy, or general weakness. There are adjuncts to complete decongestive therapy, and these include pumps, kinesiotape, and aquatic therapy, just for a few. There's additional adjuncts as well. On the first visit, you may not get any hands-on treatment. It will primarily be devoted to assessment, treatment goals, education, and agreeing upon a plan. But ultimately, I want you to leave with a self-care toolbox. You need to know how to monitor yourself. This is a great slide from Solaris, and it also incorporates, if you download the full slide, how to take measurements on your body. People can have subtle lymphedema with very subtle swelling. We call it distortion of the architectural or anatomical landmarks. You can hold some fluid on the back of your hand, on your inner arm. I have a patient that always holds it just down by the tendons of her wrists. And that pesky elbow is another place where you hold fluid. You want to keep an eye on your arm if that's the area at risk. This is an example of measurements taken by a lymphedema therapist who will take them at every 4-centimeter intervals and compare them over time, and note when your weight increases, your measurements may go up. This is an example of measurements of the leg. Stemmer's sign. If an area becomes full of fluid, it's thickened. You can feel it. Even on yourself, if you pull on an area of your skin that's not affected, you can tent it easily. If you have lymphedema in the foot or in the hand, you can't pinch the skin and have it pull up. However, a Stemmer's sign, if your lymphedema is only in your upper arm or in your thigh, doesn't mean anything if it's not there. But if it is there, it's indicative of stagnant lymphatic fluid. When I worked in radiation oncology and now, I take measurements only in a couple of places on a patient's limb if that's the area affected. I would take them 8 centimeters above or 8 centimeters below the elbow. Notice that in this patient, most of her swelling appears to be below the elbow. If you did her volume, she may not have a significant volume increase, but simply by observation, you can see she has lymphedema. I've sat at a LANA meeting and had a highly qualified physical therapist look at me and say, "You don't have lymphedema." And then she touched my arm and was shocked that yes, she could feel. I can feel when I examine patients. You can feel yourself the changes in your skin when there are stagnant fluid. So again, lymphedema can be obvious, and in this case, you can tell this patient you cannot see the knuckles or the tendons on her left hand, where you can on the other. When she makes a fist, you can't see her knuckles. Or lymphedema can be subtle. These hands look pretty similar, but when she makes a fist, you can see there's fluid hiding between the knuckles right there in the web space. Both patients have lymphedema. One is easier to see. The gear towards treating includes wrapping, and this is wrapping gear. I've seen too many physicians tell patients, just go out and get an ACE wrap. These are short stretch bandages. They do not have the elasticity of an ACE wrap. ACE wraps are too elastic. They can damage your superficial lymphatics. So to do a wrap, and wraps are a powerful tool. Patients all too often consider them punishment, and I've had wraps applied much too tightly. They hurt and they're not effective. There are good studies to show that a wrap with a lower pressure works more effectively than one with higher pressure. We all want to wring that fluid out of there, but a wrap should be comfortable. What we do is we use gray foam to build up the area and distribute the pressure. We use gauze to wrap the fingers. We use an underlayer of gauze to distribute the pressure, and then a bandage in an upper arm can be anywhere from 3 short stretch bandages to up to 6. You can get more compression by applying more layers. You shouldn't be making it so tight that it's uncomfortable. In my lymphedema training class, one of the therapists volunteered to be trained, to have a bandage applied. She found it so uncomfortable that she couldn't tolerate it. Bandages should not be uncomfortable. And again, they need to be compressive, but not so compressive that your fingers turn blue or that they cause extreme pain. This is wrapping gear taken from an image from my lymphedema therapist's office. And again, this is how a bandage looks when it's applied. Bandaging legs is very, very challenging and hard to do on your own. And even bandaging your arm initially can take up to a half an hour until you get the skill down. Daytime compression garments can be crucial. This is an off-the-counter glove. This is a custom glove with an extended wrist. This is a non-custom sleeve. And this is a swell spot, a chipped foam spot that you can put in to compress either the palm or the upper dorsum of the hand. These are nighttime garments, and again, they have chipped foam. They can replace bandaging or be used as an adjunct. Exercise is very important. This slide was supplied by the Lymphedema company. Katie Schmitz published a groundbreaking study showing that people with lymphedema, if they approach it thoughtfully and carefully, can generally do resistance exercise. And it can actually improve your lymphedema as the deep muscle contractions help move lymphatic fluid. Additionally, decongestive exercises are part of our therapy. Aerobic exercise is important for keeping one fit, and although limbs may swell after aerobic exercise, wearing compression garments can help this. Deep breathing is very important to keeping the lymphatic fluid moving, as is being fit and conditioned. Skincare is crucial. You need to avoid infection as we're a setup for cellulitis, skin infections, which can be life-threatening. So you want to keep your skin lubricated, apply topical antibiotics to any cuts or burns, avoid sunburn, and have early recognition of infection and rapid treatment. This is a page from the New England Journal where a patient who had been treated for breast cancer suddenly developed cellulitis. Notice that it's in that quadrant that we previously talked about, her breast, her arm, her back. The article stated that she did not have lymphedema, but I would argue that she did. And it's a vicious cycle because once you have an infection, it damages your lymphatics and you're set up for further infections. Breast lymphedema is extremely common because the sentinel node is the pathway for the lymphatic fluid out of the breast. I saw it very frequently in radiation oncology. It's a combination of both swelling and redness. And this article shows that the swelling tends to go with gravity and be in the lower portion of the breast, while the redness is throughout the breast. Sometimes the redness is mistaken for infection, but unfortunately with breast lymphedema, which can occur in over 60% of women who are treated with breast conservation, that they have recurrent episodes of cellulitis at times. It's treated with manual lymphatic drainage and compression. This is another example of truncal lymphedema. Patients will tell me they feel like they have a golf ball or a football sitting in their armpit. It's not a post-operative change, it's lymphedema. This poudre orange, I would see this so commonly when I took care of patients in radiation oncology, the thickening of the skin and the obvious sebaceous glands. This is a sign of breast lymphedema. Head and neck lymphedema occurs in more than 50% of patients treated for head and neck cancers. It's both external and internal, and it's also highly treatable, treated with manual lymphatic drainage and compression garments. Additionally, the drainage can be done internally as well, as it affects the inside of the mouth. This is an example of a compression garment for head and neck lymphedema. Genital lymphedema is common as well and can be treated both with wrapping, compression garments, and these are chipped foam garments. The concerns when you see a lymphedema therapist can be poor technique. I once saw a therapist who was only trained with a weekend course who slathered me with Eucerin and kneaded me like bread dough. Manual lymphatic drainage should never be done with lotion, and you just want to move the skin. Additionally, you can do everything right, and yet lymphedema can be difficult to control. In my training class, we were told that we could call for help, but not until we'd used gray foam in our bandaging. My therapist calls it whack-a-mole. You get it under control in one area, but it pops up in another. Your therapist should work with you. Your therapist should also consult their training school or another therapist if they're running into difficulties. Follow-up care. This is from the National Lymphedema Network site. Linda Boyle wrote the crucial importance of a checkup. Lymphedema is a chronic problem, and checking in with your therapist is very important. The pitfalls to getting ideal care, again, there's no single diagnostic criteria. Therapists want to be objective. Insurance tells them they have to set criteria, goals. The goal really should be focused on function and symptoms rather than simply volume. I've been told I don't have lymphedema because I don't have certain numbers, a 2-centimeter increase in arm circumference, a 10% volume increase. Patients have been told that their bioimpedance reading doesn't indicate lymphedema. Bioimpedance can measure fluid in the tissues. It's not a standalone diagnostic tool. Again, there are certain areas of the body that can have lymphedema, but they really can't be measured. So again, if a treatment plan is too focused on volume reduction, it may not meet your needs. You need to be prepared for managing a chronic disease, and you need to work with your therapist to clarify treatment and treatment goals, as they may need a mid-course correction. When I write a script for physical therapy or occupational therapy, I write evaluate and treat. Now, when I work with a therapist about a patient of mine with lymphedema, I'm highly specific about what I want. And yet, despite that, often my patients come back to me without everything that I'd like them to know. They may come back to me without garments. They may come back to me without a plan. They may come back without any concept of follow-up. And as we talked about, the Physical Therapy Association does not require additional training. I looked at a video created by a physical therapist yesterday for Pilates for breast cancer survivors, and she included lymphatic drainage, which was entirely wrong. So a little knowledge, unfortunately, can be a dangerous thing. You want to go to someone who's had additional training. A prescription does not equal close physician supervision. And again, some other qualified therapists, such as myself, RNs, massage therapists, cannot receive insurance reimbursement. Lymphedema is a very expensive disease. There are co-pays for garments, lost work, lack of insurance cover. Again, I don't want to beat up on the American Physical Therapy Association, but what I'm advocating for is clinical standards. And I do believe that clinical standards should be that you should receive your treatment, ideally from a CLT. From their site, they say if you seek treatment from a physical therapist, ask them about their level of training. And I think this is the most crucial point. Detail your symptoms and what makes them worse. Lymphedema can present as swelling, skin changes, heat, tingling, a sense of fullness. Symptoms are crucial, and there are many validated surveys that show that we can diagnose lymphedema by symptoms. Healthcare reimbursement drives care. Breast cancer-related lymphedema is covered due to federal law, and yet garments aren't covered for people over 65. Many other lymphedemas are not guaranteed coverage. Coverage is provided via a physical therapy model. Back in 2010, Medicare looked at lymphedema, secondary lymphedema again, and we had some high hopes they would change their stance, but ultimately, at this point, they haven't. I received my lymphedema therapy from a wonderful massage therapist who started with Dr. Lerner back in 1990. I pay her out of pocket and she's worth every penny. Know that massage therapists cannot bill insurance. Dr. Lerner stated in 1998 that he used massage therapists because he found that they would specialize and focus on lymphedema, and there were two exceptional massage therapists in my training class who've gone on to do wonderful work with lymphedema patients. From the Linda Boyle follow-up, good reasons to see your therapist every 6 months to prevent infection, to prevent the area from becoming larger. The biggest risk for progressive lymphedema is having mild lymphedema. To get new garments, your garments wear out after 6 months. And there's always new products, so to learn about new and improved lymphedema products. To review your self-care, we all need some reminders to stay on track and motivation, and to get support and encouragement. And this is crucial. Regular checkups translate to effective control. So how do you find a qualified therapist? Check training and references, ask about experience. Bring in the LE&RN guidelines or a resource from Step Up, Speak Out. Raise concerns. Realize that mileage may vary. Some therapists have come with wonderful recommendations, and yet for an individual, they may not be the right person to work with you. Get physician or nurse practitioner supervision and communication. Even if your primary care doesn't know much about lymphedema, or your oncologist or radiation oncologist, we have resources on our website to educate them. And I found my primary is more than willing to advocate for me, even though she may not know as much as she'd like to about lymphedema. So the ideal therapist is accessible, experienced, working with oversight, able to treat a chronic disease. The barriers: there's a therapist shortage, reimbursement is poor, treatment is often shortened. You may only get 8 physical therapy treatments per year through your insurance. There often isn't follow-up care, limited access to good fitters, no provider team, and no after-treatment toolbox for self-care. We all share common goals, self-management and control. You want to leave with the tools to manage this chronic disease because you need to review, record, and revisit. You want to follow up. If you understand lymphedema, you understand the treatment, you have a therapist you can work with, you become empowered to control your lymphedema. And I'm not sure why, but I find lymphedema a highly stigmatizing disease. I'm embarrassed. I'm embarrassed to wear my garments in public. I've worked very hard to overcome this stigma, but I feel that it persists. A good lymphedema therapist is a powerful tool and support. I'd like to thank the Lymphedema Education and Research Network for allowing me to give this presentation today, and I'll be taking questions at this point. I guess the first question I'm going to answer is, I've been referred to a lymphedema therapist and they're not a CLT. Should I seek another therapist? Well, I would say that prior, again, lymphedema therapy only came to the United States officially in 1990. Many therapists received short training. The lymphedema therapist who brought the training that I received to my state was someone who had only received short training. She, however, had a wealth of clinical experience. She was a great therapist before she became a CLT, and she continues to be a wonderful therapist. So I would bring in the guidelines for treatment and discuss with this person their degree of experience and see if they propose a treatment that meets your goals. The second question is, what should I do if my lymphedema therapist says, well, your 8 sessions of physical therapy are up and now you're discharged? I would say, how can I follow up with you? Should I meet with my primary care physician or nurse practitioner or oncologist and get a referral to come back to you? The toolbox. Okay. For me, the toolbox is first, I can hold this up, a measuring tape so I can measure the area. Second is a knowledge of garments. Third, self-MLD. Fourth, for me, I bandage every night because my lymphedema is primarily in my hand, and I have tried so many garments. I have a closet full of wonderful handcrafted garments, chipped foam garments to wear, but they just don't leave my hand in the shape that I want it to. And I can't wear compression during the day because I need to wash my hands when I'm seeing patients. So the toolbox is basically a way to surveil yourself. Garments, both nighttime and daytime. Knowledge of a lymphedema therapist that you can get a hold of. And for some people, the ability to rapidly access care if they get any kind of infection. Looking for any additional questions? The next question that I would answer would be, I saw someone and they told me that my arm wasn't large enough to have lymphedema, and yet at times it feels heavy. Do you think I have lymphedema? And should the therapist do more for me? Well, we put lymphedema into several stages, and one of the first stages is something called latency, where basically you have fluid in the tissue, and stagnant fluid basically causes fibrosis and at times irreversible changes. So yes, I would have that person teach you how to do self-manual lymphatic drainage, fit you with compression garments which you may choose to wear when you're flying or when you're exercising, and also set up surveillance. Question from Joe, when should antibiotics be used in combination when infection starts? I give my patients a prescription for antibiotics. And to me, one of the most powerful times that it was used was I had patients who very frequently when radiation was over, their family would surprise them or give them a trip to celebrate. Well, they were really at high risk. So I gave my patient who had breast lymphedema a prescription for antibiotics. She flew to a country where English wasn't the primary language and the healthcare system was a little more rudimentary than ours, and developed a whopping breast cellulitis. She was able to start her antibiotics and actually fly home and get further treatment. So if you develop a hot red patch that looks like it's cellulitis, it's often very important because the infection can spread so readily to start antibiotics and then seek medical attention. Additionally, some people feel that if something is at risk, if you basically have an injection, because we can't always avoid injections, say you may have an injection in the arm for carpal tunnel, you should then go prophylactically. Dr. Lerner used to say 3 days of prophylactic antibiotics. The next question is that a patient had 11 lymph nodes removed, and basically the patient had as much therapy as they could, but their arm's still locked. I have a patient who she's getting very frustrated. She knows how to wrap. She's really knows a lot, and yet she still has a tremendous amount of lymphedema in her forearm and hand, and she's just so frustrated. I think at that point, that's the point at which you need to go back, revisit, and try and figure out what some adjuncts to add. I've advocated for her to get a pump. Unfortunately, her lymphedema therapist doesn't like pumps and has basically talked her out of them, and I feel this is a case where it would be helpful. But we're going to work on getting her some different forms of garments to try and bring that area down. Chipped foam can actually break up fibrosis. There's an excellent question about suspending MLD when you have cellulitis. One of the best references is the International Best Practices Guideline, and they state, it was written in 2006, that you should suspend MLD when you have cellulitis. However, you shouldn't suspend compression. And this is really important because if the area of infected fluid stays, it's like an abscess, and it often won't get better even with all the antibiotics unless there is some compression applied. So what you want to do is apply, and this is where bandaging is so important because you can basically modify it. You want to apply a light wrap bandage to compress the area gently, and then as the antibiotics kick in, the compression become greater. But it's very important not to stop using compression. Suspending MLD, it's really a hypothetical because the attitude is that you're going to be moving infected lymphatic fluid and possibly spreading an infection. And yet MLD is really an adjunct to compression. But again, we don't really have good data or literature. I would say hold MLD, but definitely compress. Going back to the previous question about the patient who felt that she had all the therapy she could and yet didn't feel that the outcome was ideal, we've seen far too many patients who are told this is the best you're going to get. And I would argue, no, that's not the best you're going to get. There's always something more we can do. If you don't feel that you've reached an end goal that you're comfortable with, please seek additional consultation. We're awaiting any other further questions. There was another point that I possibly didn't make during the lecture, which is that several of the lymphatic training schools, lymphedema therapy training schools, will say that they are endorsed by the NLN or endorsed by LANA. And basically, the lymphedema training schools can be listed on the NLN, and they do pay for this advertising. The NLN makes sure that they do offer the 135-hour CLT training, but they don't endorse or apply any minimum standards. They're basically not following for quality. They are making a basic presumption and that they supply adequate training. Additionally, LANA. LANA certifies therapists as well-trained, but it's not a supervision. I sit on the Board of Medical Licensure and Discipline for Rhode Island, and it's disciplinary boards that basically provide oversight. So if you see a therapist and you're not happy with with the treatment that you receive, basically your recourse is to speak with the therapist, to speak with the training school. But know that unfortunately at this point in time, there is no supervision. Someone asked about the Lymphedema Treatment Act. Yes, we need the Lymphedema Treatment Act. One of our founders on Step Up, Speak Out just went all the way to a final appeal. She's been getting garments for many years, and at her appeal, her garments were denied as she's covered by Medicare. At her appeal, they agreed that it's medically necessary, but they said it's Medicare guidelines not to cover garments. So her lymphedema will not be treated. These garments are so expensive. We really need the Lymphedema Treatment Act, and at the last session of Congress, we had 100 co-signers. So please, if you can, I wrote to my congressman, he co-signed it. Please be aware of the Lymphedema Treatment Act. It's an act which has been previously introduced in Congress and will be introduced again to attempt to get coverage for garments, for the gear that we need to control our lymphedema, and that it be mandated and covered under Medicare. There's a comment from Joe that a combination of an informed consent works best. I still remember watching those Joanne Robic videos, and she said when you get the information, you get your power back. I think in lymphedema, as I said, in January of this year, my own American family physician told it's a peer-reviewed journal, that there was no evidence to support lymphedema treatment as being effective. Well, they referenced one 2004 Cochrane review. Cochrane reviews only look at a study if they have 120 people. There were only 3 studies. All 3 studies showed that it was effective. However, because they were different, they said further study needed to be done. So basically, the lack of knowledge persists. And again, from Elaine, asking everyone to please go on to the lymphedema-treatment-act.org to weigh in and support to help get Medicare coverage for garments. The reason we created our website, Step Up, Speak Out, was our sense that there are some wonderful lymphedema organizations, but we really found it lacking for patients to get the education they needed on a literacy level that patients could understand. Many of the organizations were really geared more towards professionals. Now, as you can see, LE&RN is really geared towards supporting and educating patients as well. And that's why we created our site, and we really have appreciated all the support that we've gotten. But here it is. It's 15 years after the American Cancer Society held the one and only workshop on lymphedema therapy. And again, we still need to understand the condition in order to get the treatment that we need. So we're waiting to see if there's any additional questions. I guess I just want to make the point again that there is no one diagnostic test that anyone can give you to tell you that you have lymphedema. Lymphedema is stagnant fluid, and it's not just swelling. It's an impairment of your lymphatic system. So I've overheard physicians tell patients that I'm so glad you're not a vain person who's concerned about swelling. Well, it's a disease, and it's an impairment of your lymphatic system. So please, it deserves to have more research. It deserves to have more access to treatment, and we deserve to have garments available. I'll continue to work, and so will all the people watching us, and learn to educate the healthcare community and educate patients so that they know. I guess if there's not any further questions, we'll probably consider ending the broadcast at this point. But again, you can always reach us or reach me through the stepupspeakout.org site or through the Lymphedema Education and Research Network. As I tell my patients, the important question always comes when you leave the parking lot. But that doesn't mean that you can't pose the question again. Well, thank you very much for watching, and I'd like to thank the Lymphedema Education and Research Network for providing me with the opportunity to speak. And this is a brief overview of how to find a qualified lymphedema therapist. But again, please, if there are additional questions, please ask the Lymphedema Education Research Network, or contact me through the stepupspeakout.org site. Thank you.